Alrighty. So yes, we'll be discussing in this workshop, we'll be discussing the five most preferred conditions, with a very particular focus on skin of color and finding differentiating factors. And so these will be our learning objectives. With the information we'll provide, you'll hopefully be able to create a more broad differential when looking at these skin conditions, and also find this critical lens on how to evaluate either your school's dermatology curriculum or your dermatology education when you're in residency, and with the goal of improving health outcomes in these patients. And hopefully by the end, you have some tips and tricks to be able to correctly appreciate the skin morphologies in people with skin of color and in people with all skin tones. Before we get started, I'm going to share this pre-survey that will give us a baseline of what people know before going into this workshop. I'll also send it in the chat. So we've allotted a couple minutes to this survey, so you can either use the camera on your phone to scan. And I'll give everyone a couple minutes. And then you could also click the link. You'll have to create an ID. This will help us track your survey. Of course, it's de-identified, but it will help us keep track of your survey with your pre and post. So that way we can look into specific differences observed after the workshop. But we won't be taking down email or any identifying information on your end. And then you won't have to fill out the demographic information at the post survey. I guess we'll do maybe 2 more minutes. Alrighty. At any point, you can click the link in the chat and fill out the pre-survey. So this is the outline. We'll discuss the dermatology disease burden, about how many percent of patients are being seen in an outpatient setting in the ER, and a bit of the issue with access to seeing a dermatology provider. We'll go into discussing the skin morphologies and their presentations for the five most referred conditions. We'll do a bit of a couple case studies and end with a reflection and a post survey. This is the part one. And so a large of the presentation of skin conditions is seen in an outpatient setting. So about 6 to 7% of patients that go into seeing their primary care provider are reporting a skin concern, a skin condition that they wish will be addressed. And even in the ER setting, there's about 3% of patients that are showing up and their primary diagnosis is a skin condition or a subcutaneous tissue condition. And when you think of hundreds and hundreds of patients being seen, this can account for a large portion of patients that are going into clinic or the ER because of a skin concern. And so it becomes even more important that these providers have the resources and tools to navigate their presentation in every shade and skin tone, so that they can then create appropriate treatment plans and make sure that the patient's receiving the care that they need. There's also an issue here with access to seeing a dermatology provider. So it takes about a month to see a dermatology um, provider after a referral's placed, and a quarter of patients sometimes report even 2 months. And why is this important, right? So they're seeing a dermatologist, but a lot of what is dermatology is the impact that the skin disease has with the way that the patient engages with their environment. And so there is a lot of data that supports that people with skin conditions have an increased risk of mental illness and mental concerns because their disease is so front facing. They get to see their disease on a day to day, and it might not be debilitating like other conditions, but the way that these conditions present on the body can really, really impact the way that patients engage with their day to day. And so when you're doing this for a month or even 2 months, it in itself, it could be very debilitating for these patients. And there's this dermatology quality of life index that uses to track disease burden in patients and the way that they are living their life. And so going on about 2 months with a condition that is still waiting to be addressed could be very challenging for these patients, especially patients with skin of color that have to wait to see a dermatologist because their initial provider isn't sure of what to do next. And so we found the five most referred conditions through this national survey. These include benign tumors, acne, non-melanoma skin cancer, contact dermatitis, and actinic keratoses. And so these are the diagnoses that are linked to the referrals that are being sent to dermatologists. So now we'll jump into looking at the presentation. And so for benign tumors, I feel like there's this notion with thinking of tumors associated immediately with cancer, but a lot of these a lot of tumors can be benign and have no risk of malignancy, but it's hard to sometimes decipher between what it can be cancer versus what can be cancer if you don't have like the training, obviously, to be able to figure out the difference between the two. But regardless, there are some couple of characteristics that might be more jarring or concerning when patients present with symptomatic tumors, right? When there's pain, they might not be well circumscribed, then that kind of raises a little red flag of, okay, something needs to be worked up here. But these tumors are benign. So we have dermatofibromas, which is just accumulation of fibrous tissue under the skin. And then there's skin tags in the bottom here, which are these like kind of mushroom lesions, kind of these pedunculated lesions, where they have like a little stalk that's adhering to the tissue, and then there's a bit more tissue at the top. Um, and a couple of differentials would be like also thinking about lipomas if there's something under the skin that's asymptomatic and well circumscribed and also mobile. Um, Something that you'll see throughout this presentation is a difference in hue. So on the left, on the top and bottom, you see presentation on white skin. And so here we have a bit more pink reddish hues versus on the right side, in a person with skin of color, there's more melanocytes, more pigment going on. And so there's going to be this, this brown, purplish, black hue associated with lesions. And so for dermatofibromas, regardless of skin color, you could do what's considered this pinch test. So when you pinch, because the fibrous tissue is adhered, the fibrous tissue is adhered to the lower part of the skin. When you pinch, it'll usually retract inward and give this dumpling appearance. And that's appreciable on skin of color and on non-skin of color. These pedunculated lesions, skin tags are also pretty easy to figure out. A lot of the concern with patients is more like the cosmetic aspect of having these lesions, not necessarily them being bothersome for other reasons. Um, but of course, when it comes to lipomas, you really want to figure out if this is something that needs to be excised, something that's cancerous. And a lot of that will come with history taking and getting an ultrasound, getting a biopsy. Um, but sometimes it might be difficult to decipher what to do next if you can't appreciate it, like the dimensionality of the lipoma on the skin. And so being able to have those initial workups to make sure that there's reassurance for the patient is really important. And so one of the second most referred was acne. I'm sure a lot of people have had their run with acne, but essentially it's a chronic inflammatory condition that's caused by increased sebum production, that clogs a bunch of pores in the face, leading to comedones, papules, pustules. Um, and so when considering this condition, you really want to consider these other ones like rosacea, keratosis pilaris, PCOS. So is acne secondary to another concern? Um, and when we look at the presentation of acne versus rosacea, it could be very challenging sometimes, especially in skin of color, to figure out what is acne, what is rosacea. Because when you're trying to distinguish the two, you really factor in, is the acne over this veil of erythema? So do they have redness under their acne? Kind of how we see in the bottom right picture versus this top picture where you see these red bumps all over the forehead, but they don't really have this kind of deep um, redness under them, kind of like it's appreciated under in the bottom picture. And then you see this on the second picture, and you see again these red bumps, but it's sometimes hard to figure out, is there redness under these bumps because of the patient's skin tone? And so that's why it becomes extra important to figure out which of these two is presenting, because the first line of treatment is different for both. And so being able to be keen to figuring out these differences is very important. Another concern with acne and skin of color is their increased risk for post-inflammatory hyperpigmentation. Even when the bumps resolve, there's this deep hue pigment associated with the healing process of acne that could take months and years on people with skin of color versus people with non-skin of color. And there's also a heightened risk for keloids, trophic scarring, that can be addressed in people with skin of color. But you have to also be a bit more careful and cautious with how you do it, because there's laser therapy, for example, that exists, but a lot of these lasers are their settings are set with people that do not have skin of color. And so when you're trying to address these conditions in people with skin of color, you can do more bad than good if you're not adjusting your settings, using the appropriate laser, and then actually increase the risk of more post-inflammatory hyperpigmentation. So it's very important to navigate using these tools and resources that exist and applying them appropriately to people with skin of color. Acne can also present due to other causes. So in um, a lot of Black and Hispanic communities, Black and specifically here in Black hair, there are a lot of products that have oils or very viscous solutions that could clog a lot of the pores surrounding the forehead. And so this is called pomade acne. And it's usually because of the actual oils and viscous solutions that are clogging the pores instead of oil, instead of like the sebum production that's natural to the face. And this could lead to acne presenting on the perimeter of the face near the hair, and this inflammation could be so bad that sometimes it could cause scarring over the hair follicles, lead to more scarring alopecias. And so this is an area that is still being researched, and there's actually not a lot of research on it. So we're hoping to highlight this disparity and increase the awareness of pomade acne amongst the communities that are most affected by it.
All right, so when we think about skin cancers, we tend to divide them into the category of non-melanoma skin cancer and then melanoma skin cancer. Non-melanoma skin cancers tend to be of the basal cell carcinoma variety or the squamous cell carcinoma. And in medical education, the way we're taught to find BCCs or SCCs is mostly a description that is only relevant to people who are light skin, and it presents quite differently in people with skin of color. And that's kind of what we're going to highlight in the next couple of the slides. Next slide, please. So this is an example of an actinic keratosis. This is a precancerous skin lesion, and we usually see these due to chronic exposure to sun. And you can see that the presentation of this lesion is quite different. On the top, you see kind of like this, like almost like yellowish scale, and then on the bottom, you see that there is some pigmentation associated with it on skin of color. So they're the same diagnosis, but they present very differently on skin of color. And so the differential to consider if you're thinking that something might be an AK is either a seborrheic keratosis or a basal cell carcinoma or squamous cell carcinoma. Next slide. And then squamous cell carcinoma. So it's good to know that squamous cell carcinomas and basal cell carcinomas have a reduced incidence in skin of color, but when they do show up, it's really hard to pick up because, again, they kind of present a little differently. And so on the picture on top, you can see kind of the nodular presentation of the squamous cell carcinoma on skin of color versus on the bottom, you see like an erythematous like plaque that's formed. And so the thing to consider as like the variation presentation of squamous cell carcinoma in skin of color. Next slide, please. And then basal cell carcinoma, we're traditionally told that BCCs present with this rolled border with a pearly nodule and surrounding telangiectasias. And so that is what we see in light skin. And so that's what we see in the bottom right picture, that we actually very classic presentation of BCC. And when we see BCCs on skin of color, it presents so differently. In the top right-hand corner, you see like this thickness and a huge a nodule almost presentation that's quite different, and it's pigmented in nature, and it's not like that pearly nodule that we see in lighter skin. So again, to remember is that these BCCs, SCCs can present as more darker pigmented lesions on skin of color rather than on light skin, where we see they're like a redness that is usually associated with that. Next slide, please. And then melanoma itself, this is a cancerous lesion that's defined by uncontrolled growth of melanocytes. And melanoma is divided into many different types of melanomas, but there's a particular type of melanoma that presents more frequently in skin of color that we'll get into in the next couple of slides. So the key findings is that important points to remember is that if you have a patient who is skin of color, African American or Asians, what we usually see is that melanoma tends to present on areas that are covered by the sun. So that includes the palms, the soles, the nail beds, and the type of melanoma that we usually see in these populations is called an acrolentiginous melanoma. And why this is very concerning is that even though there's a reduced incidence of melanoma in people with color, people with skin of color, when they do present, they're usually acrolentiginous melanomas that present on acral sites like the hands and the palms and the soles, and they tend to intrinsically be more aggressive in nature. So that's why it's important to screen patients with skin of color for melanoma on these like acral sites, because the nature of the cancer itself is intrinsically more aggressive. So it's important to catch early. Next slide, please. I think you might be muted.
Okay, there we go. This is another inflammatory condition. So contact dermatitis, which inflammation is caused because of an irritant or some external um, allergen that then leads to the presentation of redness, itching, and sometimes these little vesicles, which can kind of be like these like bullous lesions that can be fluid filled. And similar to other chronic inflammatory conditions, we see a difference in the hue. So in this more fair patient, we see this redness. And then in the top, we see a deeper pigment associated with the inflammatory condition. And so condition differentials to consider are things like atopic dermatitis, which is otherwise known as eczema, and then psoriasis and tinea, which is a fungal infection. And so historically, in the past, it was thought that people with skin of color had thicker skin, and so they were then less susceptible to irritants and to have the potential of inflammation. And this is something that I referenced in the beginning. So a lot of cosmetics, skincare companies will have these trials they lead in order to address skin concern, but their trial is usually filled with a certain population or certain demographic. And so when they're using their results as marketing tactics, there's not a lot of truth behind what they're selling you because they can say that they're addressing um, this uneven skin tone, but if you are a person with skin of color, it's going to take a lot more than a product to address your uneven skin tone. And so that's why it's important to be caution and do our own research when looking into this product because you want to know what was the population or who were the people that were used in this trial in order to see if that product might be applicable to your skin concern. And in people with skin of color, there is also lichenification, hyperpigmentation. So hyperpigmentation looks like the top patient with these darker patches in the back. And then lichenification means there's this thickening, rubbery feeling associated with contact dermatitis. And so the skin just becomes a lot more thickened. It might feel rubbery. And so that's something to look out for in patients with contact dermatitis that have skin of color. And so now we'll move into a couple case studies. And so here we have case one. I'll go ahead and read it and you can submit your responses in the chat if you feel comfortable doing so. So a 24-year-old woman comes to clinic with a concern about worsening pimples on her face and back. She described multiple red bumps and some painful cysts. Over-the-counter treatments have not helped. She mentioned increased stress, irregular menstrual cycles recently. On examination, she has numerous red bumps and pustules on her cheeks and forehead, along with cysts on her back. What is the diagnosis of this lesion? So this could be rosacea, acne, atopic dermatitis, or eczema. And so something important here is factoring in the fact that these are kind of these isolated red bumps, and we don't really see a lot of erythema, a lot of redness in the background. And redness in general in people with skin of color is hard to pick up on. Sometimes people can say that you can see this transition from what's the patient's skin tone versus another color or hue essentially. And so once you see that transition, you might think, okay, there's something going on that's leading to this different skin presentation, and that can be picked up as erythema in people with skin of color. And so yes, this would be acne. Um, and here we have a picture of rosacea on a patient. So this is like the background redness that we see, and the lesions on top of them, these bumps on top of them, are also very red. And here we see more of these red lesions, and we even see some signs of PIH. So this post-inflammatory hyperpigmentation also happening around these lesions. So those are probably due to more healed lesions, and will take some time to go back to the patient's skin tone. And for case two, we have a 65-year-old man presenting to clinic with non-healing sores on his nose that has been present for several months. He describes the lesion as a small, shiny bump that occasionally bleeds. He has a history of extensive sun exposure from outdoor activities and has had similar lesions removed in the past. On examination, there's a pearly raised lesion with visible blood vessels and central ulceration. And so here we have a couple hints, right? So this is a history of extensive sun exposure. They've had similar lesions in the past. We see visible blood vessels. There's a central ulceration. And so on dermoscopy, what you'll see is this very fancy tool that allows you to see very close up to the skin. You'll see the telangiectasias, which are caused by vascularization, leading to more vessels being prominent. So that's what telangiectasias are like these very small vessels around an area. And you see this shiny pearly nodule. with essential ulceration consistent with BCC.
Right, I can take it from here. A 60-year-old woman comes to clinic with a scaly red nodule on her nose that has been growing slowly over the past few months. She reports the area occasionally itches and bleeds. She has a history of sun exposure and has had AKs treated in the past. On examination, there's a firm raised lesion with a rough surface and some area of crusting. What would be the diagnosis? So well, I guess we can move to the next slide because I think it talks a little bit about what the hints are. So again, this is more of a squamous cell carcinoma because you see like that induration. There were some other hints in the case itself that there was a history of sun exposure, and then there's like a firm raised lesion, and that induration is kind of consistent with how squamous cell carcinoma can potentially present in skin of color versus in lighter skin, it's more of a rough, scaly patches in sun-exposed areas. Next slide. Then case 4, a 30-year-old woman presents to the clinic with a rash on her hands that started after she started using a new hand cream. She reports the rash is itchy, red, and has developed small blisters. She has a history of sensitive skin and experienced similar rashes in the past when exposed to soaps or cleaning products. On exam, there's an erythematous patch with vesicles on the dorsum of her hands. What is the diagnosis? And
Oh,
it's okay. Yeah, so someone said in the chat, contact dermatitis. That's correct. Lots of hints in the vignette itself about exposure to products themselves. And what we see in the picture itself is like the thickening and the scaling and the dryness. And so on top is kind of, you compare the picture on the top with the picture on the bottom. On the bottom is like what you see in like darker skin conditions. So instead of like redness, it's more post-inflammatory hyperpigmentation is what we see more common in contact dermatitis. So it could be sometimes hard to see contact dermatitis in skin of color because it's more pigmentation than redness. Then our last case, 65-year-old male presents to clinic with a rough, non-tender scaly patch on his forehead that has increased in size. On exam, there's erythematous lesion measuring 1 centimeter with thin white scale, and he has a history of sun exposure due to his outdoor occupation and has had similar lesions in the past. What would be the correct diagnosis for this lesion? So this would actually be an actinic keratosis because there's like that the plaque that we see is more consistent. So there's like a yellowish scale that's more consistent with an actinic keratosis over something like melanoma. Melanomas usually present pigmented dark lesions in both skin of color and non-skin of color. And then in skin of color, melanoma would be more on like the hands, on the palms, more likely. But yes, okay, actinic keratosis can develop into squamous cell carcinomas later on. And then this is just, again, a presentation of like actinic keratosis on lighter skin, and then what it can develop into, which is a squamous cell carcinoma on skin of color on the left. I can do this part too. Yeah. And then just to finalize our presentation and close it off, the purpose of this presentation was to talk about the common clinical dermatology concerns and how they present differently on skin of color. Again, we are taught in medical education how these present on lighter skin tones, but they actually present quite differently on darker skin of color, which leads to a delayed diagnosis in these populations. And then just the next steps is thinking about how you'll apply these skills in your practice. And then when trying to determine what a lesion is and you're Googling pictures, just to, like, remember that maybe to look how that might present on skin of color. And then we listed a couple of resources that people can use to enhance their knowledge on the presentation of these dermatology conditions on skin of color. And this is our post survey. So, if it's okay with everyone, just take a second to scan the QR code with their phone and just go ahead and fill out the post survey. We really, really appreciate it. Thank you so much for your time.
Any questions or comments? Thank you both for presenting. Um, that was a really good presentation. Any feedback at this time or questions, comments, concerns, all of that?
I've also linked the survey in the chat in case it's easier for anyone.
Yeah. I also copied over your pre and post. So if anyone that's doing that, they see like that is similar to what you had taken, um, you can repeat it again. You can do either one. I'll send all the data after this. I think you did a really good job. I think this is a very important topic because there's not too many publications on skin conditions on skin of color. A lot of, like you said, a lot of things are shown on light skin tones, probably because it's easier to identify. So it's very important to have modules like these that are identifying the most common skin conditions that you can come across. And I thought your case studies were really good. My biggest thing would probably be just like pacing. I feel
Mm,
like, we went through it really quickly. So in the beginning, just like slowing down a little bit more with the
mm.
information. I get like presenting could be a little nerve-wracking too. I feel like I go through my presentations very fast. It's like exciting and nerve-wracking at the same time. But just slowing down a little bit more with pacing as you're presenting the information in the beginning, and then encourage your audience to like turn their cameras on, turn your mic on, like
Mm,
I'm very thankful and appreciative of everybody that answered in the chat. Thank you for that. But again, I've said it before in the other presentations, being in a virtual format can be very difficult with participation, but just encouraging it. But I think you did a really good job of having like reflection points, making it interactive. Another way, since you ended up having a little bit time at the end, maybe when you're talking about the reflections on how to apply it into clinical practice, you can pose that as a question and then give the
mm. Awesome. Thank you.
So that's just a little bit of feedback there. Okay. I'm gonna drop the pre-survey link again. And this will be the overall pre-survey for all of the sessions. So if you attended one of the previous sessions and you didn't get to do the pre-survey, please complete that. I'll also drop the overall post-survey. If you attended one of the other sessions and you didn't get to do the post-survey yet, please complete that. Um, if you're doing the QR code survey that Alex put on here, you don't have to do both for the session. You can just do their survey. It's the same question, so that's okay. So we'll just take some time. I'll remain on the Zoom link. I know at 3 we have closing statements, but I'm going to just reach out to Dr. Sanchez to see if I can just close in this room. But don't leave yet, please. I'm going to verify with him first.